Welcome, everybody. Thank you so much for joining us today. Compassion and Choices is the leading national nonprofit organization that is dedicated to protecting and expanding person-centered options at the end of life. At the federal level, we work to advance a diverse array of issues, including expanding access to palliative and hospice care, reimbursements to advanced care planning conversations, and the prevention of unwanted medical treatment when one is facing a serious illness. And I'm going to talk about those at the end of the briefing. At the state level, our efforts are focused on medical aid in dying, and we're here today to talk specifically about our recent expansions in this field around the California's End-of-Life Option Act, which, as you know, Governor Jerry Brown recently signed into law. California is the 5th state in the nation to authorize the practice of medical aid in dying, which allows mentally capable, terminally ill adults with a prognosis of 6 months or less the option of ending their life peacefully. While Compassion and Choices is not advocating for a federal aid in dying law, we decided that we would hold this briefing for several reasons. First off, in the last legislative sessions on the state level, 24 states in the District of Columbia were considering passing aid in dying laws. These are laws that are obviously, people within your communities are talking about them. Public opinion polls show that 7 out of 10 Americans support aid in dying legislation. And if we talk about the states where there's active legislation taking place, like in California, the numbers are even higher. So these are laws that have very deep public support. And we found in California, where we ran our most robust effort, that some of the congressional delegation chose to endorse the legislation. So we're hoping that by talking with members of Congress's staff and giving you the opportunity to learn more about medical aid in dying and what it's all about, that your member of Congress will choose to endorse legislation in their state. We have with us 4 wonderful panelists today that are going to come and demystify medical aid in dying. First, over here is Dan Diaz. Dan is the husband to Brittany Maynard. She was the very brave woman who was 29 years old and got a terminal diagnosis of brain cancer and came out and shared her story when she moved from California to Oregon so she could access the California End-of-Life Option Act. Dan has been actively out on the campaign trail advocating for this legislation in California and across the country. And there's no question that his efforts in California are one of the key reasons that we saw success in California in October. So Dan will be our first panelist. Next will be Charmaine Manansala. Charmaine is the California Political Director for Compassion and Choices, and she too played a very critical role in the passage of the legislation. She comes to us with a very strong campaign background, having worked on dozens of national campaigns, and she's also worked as a policy director at all levels of government, from the White House to the U.S. Department of Labor, and she served as a legislative aide to Democratic leader Nancy Pelosi. After that, Reverend Dr. Ignacio Costuera will speak. Reverend Costuera is on the board of directors of Compassion and Choices, and he's also a human rights leader. He has been a pastor in Mexico, Hawaii, and California, and he holds a degree in theology, and he's also taught contemporary theology for the past 25 years. So he's going to talk about the religious and the spiritual aspects of medical aid in dying. And then the final panelist is Dr. David Grube. Dr. David Grube is Compassion and Choices National Medical Director. He has a 30-year career as a family physician, doing everything from delivering 300 babies to taking care of people at the end of their life. For 18 years of this time, he he worked in Oregon during the implementation of Oregon's End-of-Life Option Act, the Death with Dignity Act, and so he has firsthand experience with how this act gets implemented in the state and the positive effects that the act has had on end-of-life care within Oregon. So that will round out our presentations. I will close with a little bit of information on our federal agenda. So I'm going to turn things over to Dan, who's going to share Brittany's story.
Good afternoon. Good afternoon. Oh, that works. My name is Dan Diaz, and I am Brittany Maynard's husband. Brittany died on November 1st this past year in Portland, Oregon. Brittany and I are Californians, but we had to move to Oregon so she could access medical aid in dying in order to secure a gentle passing if it were to become necessary for her. We found out on New Year's Day of 2014 that Brittany had a brain tumor, that it was very large, and that there was no cure, only certain treatment options. Brittany endured an 8-hour brain surgery, and we researched every treatment option that was available. But the tumor was growing aggressively, and had we stayed in California, the brain tumor would have ended Brittany's life in a brutal manner. Brittany did not want to die suffering needlessly for her final few days or weeks, and be forced to suffer an agonizing death. She wanted her passing to be gentle and avoid the horrific and painful death that the tumor would enact upon her. Brittany passed away peacefully in her sleep on November 1st. This coming Sunday will be the one-year anniversary of that. In January of 2015, the end-of-life options legislation was introduced in California. I stood next to an individual named Jennifer Glass at that press conference as she explained to everyone the lung cancer that she was battling. Jennifer described the aggressive treatments that she had endured, the hard side effects that she had suffered, but most of all, she shared her desire to have some control over her dying process so that she could fear less at the end of her life. Jennifer died in California on August 11, 2015. On that Tuesday morning, I went to visit her and her husband, Harlan. I sat at her bedside. I saw my dear friend that I'd only known for 7 months, unconscious and withering away. She had not been given any food or water for 5 days. The pain that Jennifer was experiencing from the tumor, which had now spread to her brain, had become unbearable. So at Jennifer's request, and with the advisement of her medical team, she had been put into terminal sedation 5 days earlier. That was the only option available to her in California, and it's the only option available to any terminally ill individual in all 50 states. Terminal or palliative sedation is the medical practice of placing an individual into a medically induced coma and then withholding food and water. The terminally ill individual then dies of dehydration, starvation, and whatever the cancer is doing to the person. The emotion just happens. Don't let it freak you out. I'm doing all right. Jennifer died later that night, but that was not the dying process that she had wanted. Why did she have to endure those 5 days, struggling and in discomfort? My wife, Brittany, passed away gently. Jennifer's death was not as gentle. In either case, it was the individual determining that it was their time. And in either case, the end result was the same, death. But the manner of getting there was quite different. Jennifer should have had the same options available to her in California as my wife Brittany did in Oregon. Each of us as individuals should have the option of deciding for themselves how our final days will play out. A few months ago, the California Medical Association removed all opposition to this program, and in their statement recognized that palliative and hospice care are not always enough to keep a person comfortable at their end of life. And if you hear a person claim that they can keep a person comfortable 100% of the times at the end of their life, that is absolutely not true. The medical community cannot abandon terminally ill individuals like Brittany and Jennifer to die a horrific death. Death with dignity legislation allows end-of-life decisions to be made by the terminally ill individual and their physicians, working with their own spiritual beliefs and their family. It's offensive to hear people judge those of us who would want the option of having a gentle and peaceful dying process. There are certain diseases that produce horrific and needless suffering at end of life. Brittany's case was one of those. There is no glory in suffering a prolonged, agonizing death if that is not what the terminally ill individual wants. As a Catholic, I believe it is not for me to judge someone else's decision regarding their own end of life. I respect those who might make a different decision if they were in Brittany's shoes, so I don't understand why they do not extend the same respect to those of us that agree with Brittany and with Jennifer, that having this option, whether you decide that you need to use it or not, should be afforded to all terminally ill individuals so they don't have to suffer needlessly at their end of life. Nearly 70% of voters agree that a terminally ill individual should have the option of requesting medical aid in dying. Amongst Catholics, and I have the numbers for California, 60% of Catholics. I just came from Massachusetts yesterday, and within Massachusetts, 64% of Catholics agree that medical aid in dying should be an option. The introduction of this legislation in these states is an example of the elected officials showing leadership and listening to the will of the people. A few weeks ago, Governor Jerry Brown signed the End of Life Options Act in California. The governor does not normally make a statement when signing a bill. He just signs it or vetoes it. But in this case, he wrote the following, and I'll just read the last two sentences. The governor wrote, "In the end, I was left to reflect on what I would want in the face of my own death. I do not know what I would do if I were dying in prolonged and excruciating pain. I am certain, however, that it would be a comfort to be able to consider the options afforded by this bill, and I wouldn't deny that right to others." That sentence, or those last two sentences, express exactly, when I've talked with our elected representatives, that's the mindset that I always try to get them to. That if they recognize for themselves, what would I do if this was me? Put yourself in Brittany's shoes, as horrific and as difficult as that is. But then you recognize, well, I don't know if I would use the medication, but I certainly know I'd want the option. Just to have that option. I thank you for my time. If I'm assuming questions later, I'd be happy to answer any regarding the reality of what Brittany went through in Oregon, any other questions. Thank you.
Thank you, Dan. I really appreciate your honesty and perspective. I'm going to turn it over to Charmaine Manansala now, who's going to try to help talk to you about what exactly the law is, the California law, which was based on the Oregon law.
Thank you, Kim. It's always hard to follow Dan because, how can you follow somebody with such a compelling story? But I think it points to the reason why such law was needed in California and the reason why we need it across all states in our nation. Again, as Kim said, on October 5, California Governor Jerry Brown signed the End of Life Option Act. It was passed in the California Senate and Assembly on a bipartisan basis. It was signed by Republicans and Democrats. Again, this issue of end of life, everybody dies, everybody will face death, and as I always say to politicians in California, everyone is one bad death away from being an advocate on this issue. Before getting into the provisions of the law, I wanted to answer two basic questions so that we often hear from people who don't know anything about end-of-life options or medical aid in dying. Why is it needed? First, too many suffer needlessly at the end of their life. Too many endure unrelenting pain. And third, too many turn to violent means at the end of their life when medical aid would help them die peacefully. And the second question I get asked the most is, who is eligible for aid in dying? Just so everybody knows, aid in dying is not widely used or requested. To receive an aid in dying prescription for a doctor, people must be over the age of 18, in the final stages of a terminal illness as confirmed by a second opinion, of sound mind, and they must take the medication by themselves or self-administer. Compassionate Choice's main position on any legislation that gets introduced across the country is so that terminally ill, decisionally capable adults who have a prognosis of 6 months or less to live have a right to request and self-administer medication if they so choose to have a peaceful and pain-free death. The End of Life Option Act in California is closely modeled after the Oregon bill. Like Oregon's bill, California's bill requires the dying person to make 2 oral requests for the medication, 15 days apart, followed by a written request. Secondly, in addition, 2 witnesses must confirm in writing that the terminal person is acting voluntarily and is not being coerced into requesting aid in dying medication. And last, prior to providing the prescription, doctors are required to confirm that the applicant is fully informed about the alternatives to medical aid in dying, including comfort care, hospice care, and pain control, otherwise known as palliative care. In all states where we are introducing legislation, Compassionate Choices favors a medical standard of care model as ideal, in which the medical profession creates a safe and protective standard of practice with no or minimal legislative regulation, similar to other end-of-life options such as palliative sedation or voluntarily stopping eating and drinking. CNC supports legislation that, 1, again, explicitly authorizes terminally ill, mentally capable adults with a prognosis of 6 months to request, receive, self-administer medication to advance the time of death if they so choose. Secondly, that the legislation only applies to terminally ill adults who are mentally capable to make their own healthcare decision and are free from undue influence and coercion. And thirdly, treats aid in dying as one or more of the many choices under a medical standard of care, the level and type of care that a competent and skilled healthcare provider or physician would provide under any circumstance that terminally adults may consider when determining what course of treatment they wish to pursue. However, we must note that even though California is based on the Oregon bill, because the Oregon bill was passed 20 years ago, there are, in the Oregon bill, as in the California bill, I think, there are many unnecessary regulatory procedures, including a requirement for intensive state reporting that Oregon physicians and patients have found to be a barrier to accessing aid in dying. In general, CNC does not support proposed legislation that unduly limits or burdens an individual who wishes to obtain information or access to aid in dying. And in the packets that you all receive when you're coming in, it lists the types of provisions that CNC doesn't support, but let me just mention 3 of them. These provisions include erecting barriers to access the law by adding multiple request requirements or increasing waiting periods. Secondly, imposing outside legal instructions or procedures into the physician-patient decision-making process. And third, diminishing a mentally capable, terminally ill adult's control by giving another individual veto power or mandatory surrogate decision-making process. I just want to underscore that in the 30 years of combined state experience with the medical practice of aid in dying, there has never been a single instance of abuse or coercion in any of the states where this law is authorized. So Compassionate Choices advocates for a safe practice with the least burdensome regulatory or procedural requirements, resulting in a law that is accessible for patients and physicians. So as Kim stated, I know that the majority of you work in the federal level, but any support that you give to local officials in states where legislation has been introduced is definitely welcomed. And feel free, there's a whole slew of resources on our Compassionate Choices website, and of course, by contacting any of the staffers, we can give you more information. Thank you.
Thank you, Charmaine. Now we're going to hear from Reverend Dr. Ignacio Castuera, who's going to give us the spiritual perspective on aid in dying.
This is the closest thing to a pulpit I could see around here, so I see myself more as a kind of a caller commentator on the wonderful things that you've already heard, especially the experience that Dan Diaz shared with all of us. And we need to discover more similar stories around this is the way we're really going to keep on building the movement and succeed in the final event. I like the title that was given. In fact, it gave me the inspiration to teach a 6-month class on that. It's very long. It's a very difficult topic in some ways. And I want to, in some ways, reverse it, because I think when it comes to the minority communities or the ethnic communities in the world, not just in the United States, the impact should be going the other way. People, legislators and students, etc., they need to learn from African Americans, Latinos, and others that look at death as life, as part of life, as a transition, and not as an incredible tragedy. There are tragedies, of course, when someone dies before her time, as it was the case. But even in such instances, we have the opportunity to create something new and to see that person still alive. You know, that's what is happening with this movement. Brittany selected specifically the 1st of November because of her love for Dan and the stories that they had and the memories that they had. But the 1st of November happens to be All Saints' Day in the Catholic calendar. And I was baptized Catholic. Dan was, I don't know what Brittany did, but she became a saint, as far as I'm concerned. And I personally will celebrate her sainthood on this day. We don't have to wait for a pope to sanctify or to beatify anybody. And I think that when they have acted in such a way that they have become part of this tremendous movement, we, the people, need to beatify them. But back to my other point, I really believe that All Saints' Day was created precisely because it was listening to the wisdom of the indigenous folks of those days, the Celts, the Saxons. You know, we now have removed ourselves from our European roots, but in fact, every indigenous people, every indigenous culture has had this belief that life cannot be terminal, that death is a transition, that death is a beginning. And that we just need to develop different kinds of sensors to make sure that we know how to continue connecting with them. And that leads me to the second day. The first is All Saints' Day, but the second of November is the All Souls' Day, it's called in English, but in Mexico se llama El Día de los Muertos. And in El Día de los Muertos, every child realizes he is going to die. He is going to die, and the parents buy for him a skull with his name on the top of the skull, you know, sugar skull, and here we are eating our death. And we're more comfortable with that. So really, let's reverse that, and let's keep our ears open to the wisdom of the ages that has been in the indigenous peoples, that survives in our ethnic minorities here, and that can and will continue impacting hopefully the legislations in all of the states. One thing that I want to emphasize, and then is next to the last, is that I consider Brittany Maynard a saint because she really she rose above her assigned place. She was a person of privilege. She could have gone, like so many still do, go to Switzerland, some other place. She went to Oregon. And she could have said, well, the heck with anybody else. But she asked the family, now it's your task to make sure that that which is a privilege for me can become an entitlement for everybody. And that's what we're all about. That's what Compassion and Choices is all about. And the spiritual dimension will be there in order to really clarify for all that A, we are a nation that has many spiritual paths, and that no spiritual path has the right to impose its own perspective on the others, that we will be respectful, that we will be caring, that in my case, I want to learn from those others, but let no one particular one dominate and impose on others that which they need to just teach better to their own members, you know. So, as Dan already indicated, 60% of Catholics in Massachusetts and about the same in California believe that this is right. you know, and if the hierarchical leaders of that church think that they need to impose the teachings that their own people do not obey, you know, I think there's something wrong with that picture, right? And that they need to spend a lot more time making sure that their own members know at least the official, the hierarchical position. But more important, I believe that it is necessary for all people to know that in all religions, not just the Catholic Church, there is the hierarchical perspective and there is the theological perspective, the moral, the ethical perspective. That's why you have papal statements or hierarchical statements by some people, and then some courageous Jesuit like Dan Maguire and Marquette University saying, no, it's you, God, your physician, your conscience. Let us hope that you who are in positions to determine what happens in your states, I agree that we should not go the route of a federal law, that in your states you work now doubly or triply hard to make sure that what Brittany saw as a command for one man, one loving man, becomes the mission that all of us assume. Thank you very much.
Thank you. Finally, I'm going to turn things over to Dr. David Grube, who will share a medical perspective, including how aid in dying laws have actually helped improve palliative care in Oregon.
Thank you very much, and I want to thank each of the panelists, Dan, your personal stories, and Charmaine, your policy directions, and especially, Pastor, for your very wonderful comments. So I guess I'm the benediction after the sermon. So I practiced for 35 years in a little town in Oregon called Philomath. I was a general practitioner, a family doctor, and I took care of people from birth to death. The story that I'll quickly share with you is the story that needs to be told, which is the flip side of Dan and Brittany's story. And this is the story of my neighbor, who was a patient in our clinic, but not my patient, who had renal cell carcinoma metastasized to his bones, so he had uncontrolled pain, uncontrolled symptoms. He was under the care of wonderful doctors, oncologists, radiation therapists, hospice, palliative care, and nevertheless, his symptoms could not be controlled. His son called me on a day off, and I went to their home. The TV was turned up loud. I went into the bedroom and found him sitting in a chair, and he had a shotgun between his legs and had taken his life. It was a terrible, tragic, violent, horrible, disconnected situation. I had to call my wife, my practice partner. We had to do the work to help at that moment and take care of his widow. And I thought to myself, I will never, ever, ever let any of my patients get into this situation again. It's just too horrible. Well, fortunately in Oregon, in 1998, aid in dying law was passed. The statistics that we have in Oregon are here on the board for you to look at afterwards if you would like, and I'll share just a few of them with you. But what I want to share with you today is that I have information that's based on fact and experience, not only personal, but also statewide, to dispel the arguments against aid in dying, which are really based on fear and personal belief. So facts and experience, I believe, outweigh fear and personal belief. The facts in Oregon are that such things as palliative care and hospice care have never been better. Studies recently in the Journal of Palliative Medicine have shown that we in Oregon have the largest group of hospice patients and the best cared for groups of hospice patients and the least abuse of hospice patients, measured on such things as early discharge, short or long-term admissions, and that palliative care has improved as well. So why? The authors of this article said it was based on the fact that we have open discussions in Oregon on end-of-life options. People can choose, and when they can choose and they can talk about their choice, they're able to improve their death experience. We also have other unexpected consequences in Oregon. Since the aid in dying laws have been passed, there has been no slippery slope, whatever that is, that people worry about with aid in dying legislation. Has not occurred, and there's no evidence for it. As Charmaine mentioned, there's been no evidence of abuse. I served for 7 years on the Oregon Medical Board, which is the board that examines and regulates and disciplines physicians' behaviors. There was never one case, and still has never been a case, of any physician known to abuse aid in dying law. And the question about other such things as disabled will have a problem with this is no evidence that disabled people have been, this has been abused for them. Recall that aid in dying is, in Oregon now, is almost standard medical care. It's almost normalized. And so individuals who choose aid in dying are a part of a hospice. They're a part of a palliative care team. They're a part of their physician's practice. They are not disconnected, such as the gentleman I mentioned at the beginning of my presentation, who have no choice and don't know what to do and make a bad choice that impacts the family and their doctor for the rest of those individuals' lives. So in my experience, not only personal, I have had patients who have asked me to write prescriptions. I have written them. And in my understanding of the facts, looking at 18 years of experience, we don't recognize that there's anything harmful in this choice. And remember, it is an individual's choice. It's just an option. And it's very infrequently used. Last year in Oregon, only just more than 100 people chose this, and that's out of 34,000 deaths. So it's less than 0.2% of individuals. It's not commonly used, but it's a choice, and it should be a choice. And I'll close by saying that after this long clinical experience that I have had, I've realized, and I teach this to medical students even today, that there are two things, only two things that matter in end of life. One is comfort, providing whatever comfort that we can for that poor individual who's dying, and two is respect, respect for their wishes, whatever their wishes may be. So remember those two things, comfort and respect. That's what all this is about. Thank you very much.
Thank you, Dr. Grube. Now, we couldn't possibly come to the Hill and just talk about our state efforts around medical aid in dying. As I mentioned, we are not advocating or trying to pass legislation on the federal level related to medical aid in dying, but we do have a very robust federal policy agenda, and there's a copy of this in the packet that we handed out. And I do want to take a couple of moments to talk to you, and I'm truly hopeful that some of you who work for congressional staffers will hear some of the policies that we're advocating for and will consider working with us to try to see passage of these other end-of-life options that have the potential of really transforming end-of-life care here in our country. Our federal policy agenda is designed to address the challenges and the problems that were outlined in the Institute of Medicine's seminal report that came out last year called Dying in America. This was a consensus report. It was based on evidence from across the country, and it also includes many policy solutions from the leaders in the field of aging, such as the Coalition to Transform Advanced Care and the Leadership Council on Aging. Our policy agenda is here, and it reflects the opportunities and the challenges of our current healthcare system. There is absolutely no question that our world has seen tremendous and unprecedented medical advances. When you look at public health and all of the advances, penicillin, vaccines, organ transplants, now the potential of 3D printing, this is truly tremendous. And we have been successful at extending life, and these are obviously things we should be really proud of. But with these really, really robust advances, we have also seen a strain on our end-of-life care, and a whole different set of challenges are now emerging, and we as a country need to come together and figure out how do we solve these problems so that when people die, they die in a compassionate and a caring, and they have quality of life through the end of their care. Consider a couple of really important facts. 9 out of 10 Americans strongly express their desire to die at home. But unfortunately, that's not what's happening right now. The vast majority of Americans are dying in hospitals, often in ICUs, hooked up to machines in uncontrollable pain. Even more patients are entering hospice care only in the very last 3 days of their lives. So here we have an incredible opportunity in hospice to provide wraparound services to families for 6 months during the end of their life. But instead of having access to that, people get hospice for the last 4 or 5 days of their life. And the problem's growing larger. I mean, I don't need to share the statistics about the baby boomers. We all know they're getting ready to retire. We know this is a profound demographic shift, and the reality is by the year 2060, there are going to be 98 million older persons here on our planet in the United States, which is the size of Germany. It would make the population of older people the 13th largest country in the world, the 13th largest country of older people. I mean, it's tremendous. But our system isn't designed to handle this, and we need federal policies that are going to address these growing problems. Our federal policy agenda is designed to address these issues, and my own personal experiences with end-of-life issues serve as an important example of the potential value of some of the policies that we're proposing. 2 months ago, my father-in-law passed away from stomach cancer. The last 4 months of his life were extremely difficult on him and on his family, both because he was in and out of the hospital and because he suffered from excruciating pain and because his care was so intensive. It was really hard for the family to take care of him. Unfortunately, he didn't transfer into the ICU until 5 days before he didn't transfer from the ICU into hospice care until 5 days before he died because he wanted to fight. He wanted to beat the cancer. And that's really a pretty common occurrence. Our federal policy agenda has a solution for this, and it's a solution that's been successfully tested in a demonstration project. And that is that people should have the ability to enroll in hospice care, to get the wraparound services, and to still receive curative treatments. This is a policy solution that we are proposing should be implemented at the federal level that could make a huge difference for families for their end-of-life care. There's also, as I mentioned earlier, the statistics of quite a bit of unwanted medical treatment that takes place across the country. And we're offering 2 federal policy solutions to address unwanted medical treatment. First, it should be mandatory for advanced care planning documents to be included in electronic medical records. Doctors can't possibly follow people's advanced care plans if they don't know that they exist. And secondly, treatment that is provided but not wanted should not be reimbursable. Had these 2 policies been in place when my grandmother passed away, her do not resuscitate order would have been respected, and she would have had a peaceful death rather than waking up from a coma angry that her wishes had been violated. These are just a few of the elements of our federal policy agenda. I really encourage you to take a look at the agenda that's included in your packets. If, as a country, we were to take that agenda and we were to implement it its entirety, we would be offering people considerable expansion and end-of-life options, and the families that are supporting them the kind of care and comfort and support they need during these difficult times. Thank you very much for your time. That concludes our briefing, and I open the floor up to questions.
Why does this policy say 6 months? You know, why, if somebody knows they're going to die in 8 months or a year, why should they have to suffer even longer?
Sure. So the question is, why does this policy specify 6 months? Why not 8 months or longer? And I can answer. I don't know, Dr. Grube, do you want to answer that?
Yeah, I'd be happy to answer that. I'd even be happy to answer it so you could hear. That's a great question, and I was not a part of the policy or legislative process in Oregon when this was passed. But the reason was because this is for terminally ill patients, and hospice generally use that standard as 6 months. Recall that we as doctors try our best, but sometimes don't do a very good job of predicting how long a person will live. If you read Atul Gawande's book, Being Mortal, doctors often predict 500% wrong, in fact, that a person will live longer than they actually ever do. And the worst doctors who do that are family doctors, which is because we care too much and really don't want our patients to die. But I think the reason was because it kind of lines up with hospice as a more predictable effort. In fact, most patients in Oregon, in my experience, are very sick, and it's not 8 months or 6 months. It's a lot less than that, usually. Thank you.
I think that, yep, right. I think that what we can see by the question also is that this law now, or these in these 5 states, gives us also the opportunity to ask all those other questions. It's obvious that part of what was being considered was that the issue of pragmatism. You know, what if you had said, 6 years or something? It wouldn't have passed. You have to start somewhere. I received a letter from a very dear friend of mine, an email, and he says, "Congratulations, what about the rest of us?" And because how are we going to do with Alzheimer's? I was at a conference, an interfaith conference, the Tent of Abraham, that would be Christians, Jews, and Muslims, talking about end-of-life issues. And it was very good to see that, by and large, there was an agreement that we really needed to take care of the people that, from 6 months on and all that. There was one major exception, an Orthodox Jewish doctor, who immediately went on to add, I mean, it was really interesting. I don't know if he realized what he was doing. When he said, I wish I could do something if I knew for sure that I was going to catch Alzheimer's, something, and so obviously this is just a beginning, but the most important thing is opens a conversation. It opens a conversation on a great diversity of issues that are connected with that, the issue of emotions, Dan more than once has apologized. Not apologized. Now he has become a little bolder. He says, "Don't worry about it. Just I'll get with it. No, don't worry about it." What's wrong with emotions? He and I both grew up, even though in 2 different countries, with the belief that los hombres no lloran, and we were hombres 6 years old, and yet being told that los hombres no lloran. And instead of really saying, let's cry. There are moments to cry, and it's okay. Was it Pincola Estes who said that tears are the river that allows the boat of your life to move to a better place? I mean, I don't know how many of you have read that book, but it really spoke to me when I heard that. And so it opens a great variety of issues.
Thank you. Let's see the person over there.
I heard about it in Baltimore. I was sound like against this whole thing, and I'm not at all. And we're working to try to get it considered. But as these folks in the East will know, that Maryland failed to get it out of committee until last year. And one of the glitches was my senator, Jim Grochman. And I had lunch with him, kind of talking into this situation. And he had several complaints about what the legislation is, but share those as the needs of this committee responded. First, he said that you can commit suicide anytime you want. There's no law against that, and there's no repercussions. And I tried to share the kind of story which I dealt with too. Shotguns that didn't kill you. The guy blew his shoulder off right there. So he was not convinced. He also complained that paraplegics and people of that nature cannot self-administer because they can't get their hands to their mouth and they would need assistance. And I tried to suggest that, like you were saying, it can't all be done at one time. We need to do some other work to get started. And then demented patients, of course, by definition, cannot offer consent. And those were some of his complaints. But I think they're also more political about it. The Jewish community, conservative Jewish community in Baltimore, which is very significant, the Roman Catholic community, hierarchy, not the everyday people, and a number of African American Protestant American pastors have also come to him in opposition. So collect that, and if you could make some responses to help me and help others get beyond it. I spoke to the House Chairman and asked if we couldn't assign the thing to the bill this year to a different committee. The Jim's not on, but it's going to be difficult in there. Thoughts about how we might
Yeah. So let me take the questions one at a time, and I'll select panelists, and I'll start with the sort of, is this suicide, and let Dan answer that question.
So the opponents love using this word suicide. They know it's inflammatory. They know it invokes fear. suicide. Somebody's ending their life. Somebody wants to die. When I've heard that, and I'll share briefly a senator from California who highlighted the same thing, that if somebody wants to commit suicide, his words on the floor of the Senate, slash your wrists. I couldn't believe that he was saying this. Like, wait, this is a matter of public record. He says, if you want to slash your wrist, slash your wrist. You want to drive over the cliff, drive your car over the cliff. The term suicide applies to somebody who is depressed, despondent, making irrational decisions. Whenever I've heard that term, I've asked the individual who said it to say, well, tell me again how Brittany was suicidal. To which immediately they say, well, no, I'm saying she committed suicide. Yeah, but you cannot separate those two. If a person committed suicide, it means that they were suicidal. And anybody who knew Brittany, including all of her physicians, said, well, there was nothing suicidal. There was not a suicidal fiber in Brittany's being. She was simply taking the control back from the tumor so she could have a gentle passing. She was not making irrational decisions. She was not depressed or despondent. If anything, those were very rational decisions that she was making, taking the control back from the tumor. So with regards to that word, I would say that the opposition does like to use it. Physician-assisted suicide. Well, we don't use those terms. Medical aid in dying, end-of-life options, that accurately describes what this program is about. And for those who use that term suicide, it is because they know that it invokes fear, uncertainty, doubt. Oh no, this term. So with regards to that first one, I correct every, whether it be the media or any opponent when they bring it up. I share with them that the act of suicide is actually something where those individuals do need appropriate care. They do need attention. But a person who commits suicide is somebody who wants to die. My wife, Brittany, wanted to live. And the tumor, unfortunately, was not going to allow for that. So with regards to that point, share that.
Thank you, Dan. The next two questions were really about the law, so I'm going to let Charmaine answer them. It was paraplegics and sort of how do you handle that, and what about somebody who's not able to consent?
That's actually more of
Oh,
the
okay, go ahead.
groups. Yeah.
Well, these are valid questions to talk about. It's and they're hard questions because that's one of the first questions those are the first questions I always get asked. But the answer in Oregon is pretty clear. You have to be mentally capable. You cannot have dementia, and no one else can make the decision for you. So at this time, that's not an option for someone who would like to consider that in the future if they become demented. It's just not part of the law. In regard to self-administration is taking the medicine without anyone else giving it to you. But that is, if you can suck out of a straw, that is how a paraplegic could use this. But recall, a paraplegic might not meet the criteria if they don't have a terminal diagnosis. So a paraplegic isn't really necessarily meet the requirements. Would have to have the 6-month diagnosis. But self-administration is the ability to consciously understand what you're doing and taking the medicine through a straw, possible.
And then I think the last part of that question was how do you handle other religious opposition, and I'll let Ignacio respond to that.
Very carefully. Well, in a way, my response has the serious side of it. Humor sometimes is the best way to deal with that. But try to talk a little bit with them. But I don't think that's where it's at for us. I think that we're not going to convert them. We should not be mean to them or anything like that. But in fact, we should really be talking to those who are capable of making the kinds of decisions we want them to make. For example, I didn't take too long with the doctor that I mentioned who was a Jewish guy of the Orthodox. How many Orthodox Jews are there? You know, very few. So I'm not. Well, yeah, their power and influence is great, no question about it. But the majority of Jews are just not connected to synagogue or temple. The majority, that's a fact. That's the statistics. And interestingly enough, in my opinion, because some of my very, very best friends are secular Jews, the depth of their morality and ethics surpasses that which I have seen from even from some rabbis. So it seems to me that we need to just choose who we're talking to, and we're not going to be talking to those that are so entrenched already in the position that. So the thing is, how many are still in the middle? How many are convincible? You know, how many are movable? Instead of the ones who just say, you know, I know that Christians the same way. You know, I mean, I'm a United Methodist. There's a group that calls itself the Good News Caucus. It's Bad News Caucus. You know, I don't talk to them anymore. I don't waste my time with them. I know them, and I read their stuff, so I know what they're saying, especially if they're saying about me. But I'm not going to be wasting my time, my energy in those kinds of things. I'm going to look for allies. I'm going to look for people that will make it possible for us to do that which needs to be done.
See a question back there?
This doesn't affect me necessarily now, but someday it's very likely to. So I have a question that's maybe a little less on the emotional side and maybe more on the evidence side of things. And it really has to do, I think, with two things. One is, and this is how I typically argue with my friends, they sort of sit down, shut up, and go away. It surrounds really the statistical use of the medications, which, Doctor, I think you said last year, 2014, something around 100 people really only ever used the medication, which I think is a very startling number, and I think a lot of people would probably be shocked to know that it was that few. Because I think many people believe that there are just folks killing themselves left and right now that these laws have been passed, which of course anyone who bothers to do any bit of research knows that that's absolutely not the case. It's just having that freedom is really all most people really want.
Amen.
Amen. And the second part, of course, and this is really maybe more of a statement, it's that certainly for me, and I believe it's the case for most people, I don't want the idea that once I'm gone, that the people who were there with me at my passing could then face all sorts of legal issues and questions and likely arrest and prosecution because they in some way perpetrated a crime against the state or the federal government by merely witnessing what I may have done to end my own suffering. And so if I'm trying to break out a question in all of this, it's that don't those two very maybe fact-based points help move this argument beyond what a lot of people have to say when it comes to the emotional reaction of, you know, oh, that's just an easy way for people to do away with the less or more disabled individual. Thank you and thanks.
So Dr. Grube, let me just repeat the question first so that we have it. So basically the question is, the fact that, oh, now I forgot the question. Go ahead. Sorry.
Well, I did not mention a significant component of your question, and so I'll answer a question you didn't ask. And that is that only 2/3 of people who get the prescription actually take it. So last year there was about 150 prescriptions written and about 100 people took it. That's been typical every year. Why is that? That's another question I'm always asked. And the answer is because people want control. As Brittany wanted control, they want to control the timing of their death or the situation of their death. They're going to die. It's not that they're dying or not, they're going to die. And so once they have that control, and I've seen this personally too, that it's a great relief for them just to know, and they don't have to take the medicine now, they have that. In fact, that's the number one reason each year that people choose this option in Oregon. It's not pain, it's not suffering, I should say. There's a certain existential suffering, but it's not the things you might guess. It's not incontinence, it's not bed sores. It's, I want to have control of this, have my autonomy, and I've lost anything that I can recognize as a value in my life. And then the second part of your question has to do with that situation. Yes, in Oregon, because this is legal, you are allowed to have the hospice nurse in your room who will not abandon you at the end, as might happen if you did some other thing. You are connected at the end of your days. Your family is there, your loved ones are there, they're holding your hand, there's music, there's candles. It's home, it's at your home.
I could add just real quick on that. On November 1st last year, and by the way, November 1st got thrown about a lot, and it really was upsetting to Brittany. By September, the torture of the tumor, she was already feeling that. She was living that daily. The seizures she was having, the pain, the inability to sleep for days on end. The reason that she set November 1st as a goal, and the media ran with it, but it was simply that our wedding anniversary is September 29th. She wanted to be able to live through that, to celebrate that. And then my birthday is October 26th. And so she set November 1st as a goal to make it to that day, but of course beyond. But what was driving her decision was how she was feeling and the symptoms that she was suffering from. And even that morning, she had a small seizure, and what was coming next for her was if she suffers a stroke, but becomes paralyzed, inability to swallow, she would be stuck. Then she would be forced to die the exact way that she was trying to avoid by us moving to Oregon. So for her, the November 1st date was just, like I said, a goal for her to get to and beyond. On that day, November 1st, secobarbital, by the way, is the medication in her case. It's a sleeping medicine. And I mentioned that just to demystify. Everybody talks about like this black pill or something. It's like, no, or it's an injection. No, the patient has to self-administer. So on that day, within 5 minutes of taking the medication, we were talking, she fell asleep very peacefully. Within 30 minutes, her breathing slowed to the point where she passed away gently. The brain tumor would not have allowed for that passing. And it was evident every day what she was suffering from. So that's building on what Dr. Grube mentioned, that it is for the individual from the time she applied for the medication until the time that she decided, if she needed to at all, but the time that she decided to take the medication, she was the one in control. And like you said, that's when you're facing death, that's huge, the idea that you have just that little bit of control. So, end-of-life options legislation, it does not result in more people dying. It results in fewer people suffering. That's what it boils down to. Other questions?
Yeah.
I'm Catherine. I'm a physical therapist that works in a hospital here. And also, we just lost my twin sister a few months ago to ALS, 2 days after her 32nd birthday. And I had told you I was fortunate enough working in healthcare and having worked in ICU that I could help her and advocate for her and fight for her family. And that responsibility was something I took very seriously, and both of my parents and my sister's husband have said to me how grateful they were that we had what we had, because most people do not their loved one through this process, what's going to be the education for them and how they may bring up this topic, how even for them to become more comfortable with it.
So just to repeat the question is for physicians who are now implementing this legislation, what is the process for getting them trained so that they know how the law works and how to treat their patients?
Well, thank you for asking that question. I've been involved in teaching this I'm going to be doing more of it all the time. I've taught we have 2 medical schools in Oregon. I've lectured in both of them. I've been to many different medical staffs in Oregon, although Oregon now over 80 doctors have been writing prescriptions. I expect that we'll be called to California. I expect that curricula will be developed. I would hope that that would be one of the values and missions of Compassion and Choices. I'm sure that it is, but it's going to be in development. And you know, Dr. Gawande in his book, Being Mortal, was incorrect in his comment that 97% of medical schools don't teach end-of-life care. Majority of medical schools teach end-of-life care. They just don't do enough of it, and they don't offer all the information and education that they should. So there'll be challenges, and I hope we'll rise to meet them.
And just to build on what Dr. Grube said, in Oregon and in the other states that have authorized medical aid in dying, Compassion and Choices does have what we call an access campaign, where we're reaching out and trying to ensure that the medical community has the information that they need in order to effectively implement the legislation, and we're getting ready to roll that out in California. In the back. Right. So the question is, voluntarily stopping eating and drinking is another potential option, and should that be a part of the public debate? And Dr. Grube, do you want to do that, or do you want me to answer that?
No, I'd be happy to talk about that. Well, that is time immemorial. I mean, that's the way that most elderly people pass away. That's the way my mother died, was voluntarily stopping eating and drinking, although she didn't know it and had suffered before that happened. It is essentially a part now of many hospice programs as an option, along with palliative sedation, voluntary stopping eating and drinking. It is generally a prolonged experience. It's not. It generally takes quite a number of days, and people die of dehydration, and that's not painful, generally because they've already fallen into a coma. Issues about voluntary stopping eating and drinking are generally that there needs to be some kind of hospice or support. Generally, families just can't provide voluntary stopping eating and drinking. It's not illegal in any state to have voluntary stopping eating and drinking, because it's a choice of the patient, and you know, it's like just not wanting to take, being arrested for not taking your penicillin, or being arrested for not taking your insulin. So if you do choose not to have food or water, the problems, of course, are institutions. When you're in an institution and the CNA brings you food by every day. But policies are being developed, and it's a great thing to be talking about. And we do have that as part of our agenda in talking about it nationally. Well, it's nothing about the doctor. There's no doctor that can get into trouble for... Our problem as doctors is telling people to do everything every time. That's our problem. That's the default. And for doctors to say, you know, you don't have to do anything that I suggest, it's your choice, doctors can't be sued for that.
So thank you all for coming. We are past our time now, so I'm going to go ahead and close the session. If people have questions, several of us will be around, and you're welcome to come up and talk with us further. Thank you so much for coming.
Thank you. Thank you. Yeah,
Thank goodness.
I'm happy to be here.
Thank you so much. Where are you?
Hi there, how are you?
Are you taking questions?
Hi.
Can I give you a hug?
Awesome. Absolutely. Thank you very much.